Our next topic would be choledochal cyst. So, what is choledochal cyst? It is cystic dilation of the common bile duct. So, there was a gentleman called Mr. Todani who classified the cystic dilation, or rather the choledochal cyst, into various types. So, Todani classification. Now, here I've added an image from the internet source which basically explains the various types of Todani classification. Now, the first image shows you the normal biliary tract anomaly. Now, when you look at the type 1, you will find that there is a fusiform dilation of the common bile duct. That is fusiform dilation of common bile duct. This is also the most common type. Now, as we go to the second time, you will find that there is an outpouching from the common bile duct. So this is nothing but a diverticulum. So this is the diverticulum of common bile duct. Now going to the next type, you will find that the CBD is dilated at its end part, and as we had read in the anatomy, the end part is the intraduodenal part. So it is the dilation in the intraduodenal part. So type 3 is dilation of the biliary tract within the duodenum. Now coming down to the fourth part. Now in type 4, which is further classified into two parts, type 4A and type 4B. As you see in type 4A, there is dilation at the intrahepatic part, there is dilation at the extrahepatic part. So basically type 4A is dilation of intra plus extrahepatic, right? In type 4B, you can see the difference that it is only dilated at the extrahepatic, right? So this is dilation of only extrahepatic. In type 5, you see that there is a dilation of the intrahepatic. So this is dilation of intrahepatic part, and this type 5 is also called as Caroli disease, right? Now there are few one-liners which have been asked in Caroli disease, which I would like to just discuss it over here. One is, it is more common female. Second, there is a radiological sign which is seen, which is called as a central dot sign. And third, it is associated with cholangioCA, polycystic liver disease, and congenital hepatic fibrosis. Now coming down to the various clinical presentation of the choledochal cyst. Can present in any age, but it is common below 10 years of age, right? Then what will be the clinical presentation of such patient? They may present with fever, abdominal pain in right upper quadrant, jaundice, right? It may also present with cholangitis. Now Why does this choledochal cyst occur? One of the most important theories given is that there is this pancreatico biliary reflux. As we all know, in the duodenum, there is the opening of the second part of the duodenum, opening of the bile duct and the pancreatic duct. There's the pancreatobiliary reflex, which allows reactivation, or rather the activation, which allows the activation of pancreatic enzymes in the duct, which causes subsequent inflammatory response, which comprises the integrity of the duct wall. And results in dilation. So the main important pathogenic factor over here is the pancreatic biliary reflux, which allows the activation of the pancreatic enzymes in the duct, as a result of which there is an inflammatory response, compromising the integrity of the duct wall, which results in the dilation of the duct. Now, the investigation that we do over here is USG, which will tell about the dilation of the duct, but our IOC is MRCP. There is no confusion regarding this, that MRCP is the diagnostic investigation of choice for choledochal cyst. Now, for our treatment part, how do we treat it? We excise of the cyst plus Ru and Y hepatico jejunum stop. Right. At this point, I would just add one more extra question over here, which has been asked in few of the recent exam regarding what is leading technique. So what happens in leading technique is that over here the cyst is densely adhered to portal vein, which is usually secondary to the long-standing inflammation. So what happens is the serosal surface, which is adherent to the portal vein, with is left behind, while mucosa of the cyst obliterated by curettage or cavity. Next question asked you in choledochal cyst is the treatment, which includes the excision of cyst plus Ru and Y hepatico jejunostome. So to summarize our choledochal cyst, it is cystic dilation of the common bile duct. We have a Tudani classification which is used for choledochal cyst. Most common type is type 1. Caroli disease is type 5. It has central dot sign. can present in any age, but it is more common below 10 years of age. Usually presents with fever, abdominal pain, right upper quadrant pain, jaundice. The most important pathogenetic factor is the pancreatobiliary reflex, which occurs due to the anomalous pancreatobiliary duct junction. The investigation of choice is MRCP, and for treatment, it is excision of cyst and Roux-en-Y hepaticojejunostomy.